orange bile pigment produced by the breakdown of heme and reduction of biliverdin is called bilirubin. Heme in the presence of heme oxygenase is converted into oxyheme. Oxyheme in the presence of heme reductase is converted into biliverdin. Biliverdin in the presence of biliverdin reductase is converted into bilirubin. This bilirubin is the form of unconjugated bilirubin which is not soluble in water. Hence, albumin is required to transfer it to the liver. The bilirubin is converted into conjugated form of bilirubin in the liver, which is water soluble. This reaction takes place by the combination of gluconic acid with the unconjugated bilirubin. Then it is transported through the biliary channels to the duodenum and from the duodenum to the colon. In the colon, there are a number of microorganisms that convert the bilirubin into urobilinogen and stercobilinogen. Majority of these are excreted in the feces as stercobilin, which gives yellow color to the feces. 10 to 15% of these compounds are reabsorbed in the blood and some parts of that reach the liver. This is known as the enterohepatic circulation. Few percentage of reabsorbed compounds reach the kidney and are excreted in the urine in the form of urobilin.
Called hyperbilirubinemia is yellowish coloration of skin and sclera. It due to deposition of bilirubin due to some abnormalities. These symptoms happen because the newborn liver is not mature enough to remove bilirubin quickly, so it gets accumulated in the body, giving the body yellowish appearance. In sclera, bilirubin is found to a more than 2 mg per dl, and in skin it more than 5 mg per dl. The load increase due to high hemoglobin concentration as well as decreased conjugation of bilirubin in liver. In neonate jaundice can be two types, physiological and pathological. And the most important feature is that physiological jaundice is usually visible in 2 to 3 days after birth, whereas in the case of pathological jaundice, it appears within 24 hours. In physiological jaundice, total serum bilirubin rise less than 5 mg per dl per day, whereas pathological jaundice, it rise more than 5 mg per dl per day. The physiological jaundice usually resolve within a week. In the case of pathological jaundice, it persists beyond 2 weeks.
Talk about the etiologies of jaundice or hyperbilirubinemia in neonate. Then there are several types like pathologic jaundice, physiological jaundice, and then hemolytic jaundice, and then there are some subtypes, for example Rh incompatibility, ABO incompatibility, and then G6PD deficiency. Then first we will talk about the pathologic jaundice. So if jaundice occurs in neonate within 24 hours of the birth, then it's your pathologic jaundice. Then examples are as showing in the slide. Some of our Rh factor incompatibility, ABO group blood group incompatibility, then mild BG incompatibility, and then TORCH, and then transitional familial neonatal jaundice. Then if the jaundice occurs after 24 hours and before 72 hours, then that's your physiological jaundice. And then usually physiological jaundice resolves automatically within 8 to 10 days. Then the examples as showing on the slide, some of them are hypothermia, prematurity, hypoglycemia, and then hypoxia. Then if for example if jaundice occurs in neonate after 72 hours, then that's your already prolonged jaundice. Examples are as showing in the slide. Some of them are TORCH, sepsis, hypothyroidism, and then breast milk jaundice. In breast milk jaundice, usually we just discontinue the breast milk, and then drug intoxicity, and then galactosomia.
Here is the physical examination of the neonatal jaundice. Firstly, we have to properly classify the infants according to their gestational age and the weight. Then we have to check for pallor, who is the pale skin, and petechia, who is the purple or red spot on the skin. And we have to check for any bruises or cephalohematoma, which is the accumulation of blood in the head of the infants between their skull and scalp. Then we have to check the urine color, if it's dark or clay colors too, and other examination geared to specific causes. And here is the lab investigation. Firstly, we have to check for the total serum bilirubin with conjugated fraction. Then we have to check for hematocrit with RBC morphology and reticulocyte count. Next, we have to check for the blood group and RH type of the baby with direct Coombs test. Then we have to check for the blood group and RH type of the mother with indirect Coombs test. And comes the specific investigation with suspected specific problems like HDB, that's the hemoglobin electrophoresis, thyroid function test, then liver enzymes, and then prothrombin time and partial thromboplastin time, urine culture. And then we have to check for the blood culture, reducing substances that contain sugar and urine organic acids and serum amino acids. And then we have to check newborn screen of the G6PD, that's the glucose 6-phosphate dehydrogenase deficiency. And we have to check for the liver and UTS, that is the urine toxicology screen.
Treatment. Phototherapy is a treatment with a special type of light. It lowers the bilirubin molecules in the baby's bodies. Blue-green light at the wavelength of 430 to 490 nanometer. It converts unconjugated bilirubin molecules into a water-soluble isomers and excretes out of the body. Types of light used here are chlorofluorescent lamp and new LED light. Certain amount of light should fall on the baby, and while doing this therapy, you should cover the eyes and external genitalia. At the distance of baby 30 to 40 centimeter. Adverse effects here are dehydration, hypocalcemia, and bronze baby syndrome. Exchange transfusion. Double volume transfusion is 160 ml. If hemolysis is severe, you should give O negative blood.
Complications of hyperbilirubinemia. High levels of bilirubin that can cause severe jaundice may result in serious complications if not treated. Acute bilirubin encephalopathy. So what is acute bilirubin encephalopathy? Bilirubin that is toxic to the brain cells of the brain, and if a baby has severe jaundice, there is a higher risk of the bilirubin passing into the brain, and it results in a condition called acute bilirubin encephalopathy. Prompt treatment may prevent significant lasting damage. So what are the signs of this acute bilirubin encephalopathy? The signs include listlessness, which is the baby has no interest or no energy or enthusiasm, and difficulty in waking, and crying, and poor sucking or feeding, fever, and significant pain on the back and the neck, and prognosis of the hyperbilirubinemia. Early recognition of the hyperbilirubinemia can prevent severe brain damage. Thank you.